Hello and welcome to On the Record. From the very beginning, we've always known that having the right allies is so important in a time of war. As we work to try and stop the spread of COVID-19, we've also come to know the importance of having all hands on deck, even those hands that come from the private healthcare system. From the very beginning, Doctors Hospital has played a vital role, even as a private healthcare provider. In this edition of On the Record, we're going to take a look at Doctors Hospital, the private partner in a very public fight. The project really pays itself back.
Correct.
They set up
at the conference, more the school.
As a journalist, I always have to focus on the facts, and sometimes that means going to investigate for myself. On the Record, Thursdays at 8 p.m. right here on RTV.
For the first time in generations, healthcare systems around the world have been stretched to the limit, seemingly all at the same time, in a fight to try and stop a highly contagious, deadly virus. And from the very beginning, Doctors Hospital has been at the forefront.
In the early days of the virus, we knew our public healthcare system could not respond in its current state. The second largest healthcare facility, a private hospital, was on the alert. Early February, the Prime Minister approaches the hospital about using the facility. They responded as a good corporate citizen.
Anything that we can do to help our Bahamian people, that is definitely what it is that we will do, always. When the facility is jointly managed, meaning that all of the staffing at the facility belongs to Doctors Hospital, all of the equipment is from Doctors Hospital. They collaborate and decide based on the presentation of the patient, based on test results, based on the condition of the patient, who will go to Blake Road. And that can be either from Doctors Hospital, South Beach Clinic, or the Princess Margaret Hospital. Once that decision would have been made, those patients are transported either by our ambulance service or the Public Hospital Authority's ambulance service to the Blake Road location. There they're received into an examination room, and an assessment is performed along with all of the diagnostics that they would have had. Now at that facility, I'm not certain if you're aware, we do have laboratory and imaging capabilities. So if those things would not have been done, for example, the chest x-ray or the CT of the chest, and bloods drawn, we have the ability to do all of those things. So that then determines what condition the patient is in. Are they seriously ill to ICU status, IMCU status, or med-surg status? And that determines which part of the facility that you actually would go in. Now, we have capabilities to ventilate clients as well. There is walled piped suction as well as oxygen throughout the facility. And then, of course, there are negative pressure rooms, which really aids the healthcare workers who are working along with the patients in keeping them safe as well. There is a main entrance to the facility where associates don and they put on their protective equipment. And then they enter what we call the treatment area. All of our records, medical records system is electronic. Our medications are served from what we call an Omnicell, which is also an automated system, all connected to the main plant here on Shirley Street. Therefore, if we have any situations where medications are going down, we have the capability of knowing they've used 10 of this, I need to get down there and restock. For example, physicians are able to review the client's medical records, any documentations that would have been made from anywhere, from home. From here at the main plant, or we do have a facility, a room that is set aside for physicians where they can view the patient's records. Now,
our main intent, especially during the COVID pandemic and the COVID response, is to make it very clear to the Bahamian public that this is business unusual, and the focus has to be on availing whatever it is we have that the Bahamian public need. And it was timely because we happen to have a very strategic and essential resource at the right time. And for us to prepare it or refine it for the purpose probably took us some investment, some money, but also took us maybe 3-5 days, and we hadn't the need to start to use it maybe for about 2 weeks. But that was, like I say, timely. So our essential role then is to partner with the government, cooperate with the government, but primarily to identify, and you know, this is connected to our overall intent, even pre-COVID. And sometimes it's very difficult to understand doctors' hospitals' role in the healthcare space, other than, you know, it's a business, you have to pay, you got to bring your land papers, blah blah. This is a great opportunity for us to use this cooperation and partnership with the government to keep the momentum going on shifting the perception of Doctors Hospital in the community, not removing the fact that, you know, we're a business, we're publicly trading, we have 1,300 shareholders, and they would like to know that we are increasing the value of their investments and also providing them dividends. But really important is that we are perceived as a healthcare experience that's doing all it can to improve accessibility, affordability, and regardless of COVID, to ensure that whatever we have that's not available in the public sector through some formula can be availed.
As it became inevitable that we would have to respond to the presence of the virus, the hospital began to respond. Everyone had to be screened. All foot traffic was channeled through one door. Visitors restricted. Elected procedures stopped, and pharmacy services were now moved to curbside pickups.
It has caused us to look more deeply at how we see regular patients, for example, who would come to prime care, family medicine clinics, in that those persons are seen through something we call telehealth medicine, where the physician can see them and talk to them virtually, and where they can book appointments, that sort of thing, you know, make appointments for diagnostics and on and on. So the waiting rooms then become almost empty. Emergency room is still open, but now we're screening everyone that comes through. So that's a major change. It's not, you know, 3 or 4 different doors open with access, and it's not everybody comes to work and no one is screened. It's everyone is being screened. It's a restriction in services. It's a restriction in the way we interact with our clients. And, you know, it's basically cut services in half. So the amount of patients we have that are in hospital presently is half of what we would normally have. We changed some of the screening, like I said, the triage process that's usual in the emergency room, that would happen more at the center of the hospital, then came to the front door, and so persons were triaged at the front door. If you presented symptoms of COVID or answered questions that led us to believe that you're a suspect for COVID or a person under investigation, you are channeled into a different area as opposed to the persons who would come in with a broken bone or having an asthmatic attack or something else.
In short, it disrupted the hospital's operations.
Disruption, right? And whereas many times people think disruption can be a bad thing, we've always enjoyed disruption at Doctors Hospital. Because when you have that, then you have opportunities to change things and to make an impact. So it's been very disruptive, but it has not all been negative. So for instance, at the very beginning of the pandemic, we had to shut down our entrances. That was the first thing we did. We had one main entrance. We were screening all patients, so that was a workaround. Then we had to shut down services that were non-emergency services. So we were only catering to emergencies, to urgencies, people who required that very high level of care. So we had to essentially shut down a great deal of our services because we provided a plethora of outpatient care services, imaging, lab, pharmacy. We had initially shut down, but now we're more open because we're able to do curbside, as well as some deliveries as well too. But definitely just with that was a huge disruption. Then of course we know the story about Doctors Hospital West and how that is now a center for the treatment of very ill tertiary level COVID positive patients.
As a private hospital, they've had to maintain a level of service to patients, regardless of this threat.
Indeed, it is a challenge. It is a challenge worldwide, but we're up to the challenge, of course. First of all, our healthcare teams are dedicated to patient care. I mean, a patient with COVID is a patient, and they require care. But of course, we have to keep our staff safe as well as our patients safe. So what do? We make sure that our staff have all the necessary tools that they need to care for patients. So that's PPE, that's making sure that we are well stocked with PPE, make sure that we have all levels of PPE. At Doctors Hospital, because we were always really on top with things like infection prevention. We are the only JCI accredited institution in this part of the region. And so, so we go through this every 3 years when we get reaccredited. And so when I say that, we have to prove that we are stockpiling PPE, that we have a pandemic plan, that we are able to respond in kind, and that we will be keeping our staff and our patients safe. Patient safety is huge for us.
As patients declined, so did the revenue.
So we anticipated that we would see maybe a 30-ish% reduction in revenue. By the time we got into May, so this was an anticipation in early April. By the time we got into May, it became apparent that our revenues were going to take a dive somewhere to 40-50%, which is significant. We know that down the road from this, then, in about 3 months, so somewhere around July, August, that's going to be reflected in significant reduction in cash flow. So we then looked at what would be really important for us to do and what would be a hugely important statement for us to make. So we spoke about making our services available to Bahamians as necessary with the cooperative venture with the government. That's one. The second really important thing to us was our associates. We have 530 full-time and part-time associates with a payroll of somewhere around 26-27 million annually. That's a significant contribution to the economy of the Bahamas and a significant contribution to Bahamian livelihood. So we thought that the first thing that's really important for us to do is to reassure our associates that their current employment would not be threatened for a certain period of time. And we elected to go with 3 months.
As we approach that 3-month threshold, there is still a lot of uncertainty as to what the future holds. Despite progress towards flattening the curve, some austerity measures may yet be necessary.
We are currently looking at a whole variety of formulae and arrangements, which importantly sit within the law, are consistent with, compliant with the law, but are saying in a general message to associates, we know that your livelihood is important. Perhaps you could partner with us and start to look at some kind of hybrid or blended arrangement in employment. A 40-hour work week, perhaps we could start to look at 30 hours, 20 hours, an organizational-wide reduction in salary, 10, 15%. That's a conversation that we're having. So from the top down, you give the message that let's all participate. Let's not pick on any particular group of associates.
But as the company's president sees it, their financial resiliency will help to cushion the blow. This as patients continue to seek care at the facility.
Because as a healthcare facility, all of the non-COVID illnesses, heart attack, stroke, uncontrolled diabetes, the necessity for surgery, deliveries, etc., continue. And so that segment, non-COVID segment, is providing us the opportunity to have a utilization that's not significantly disturbed, notably, but not significantly. By that I mean, 60 or 70%. Then, okay, now we anticipate a bit of a return of our outpatient business, which would allow us to see a better security of revenue. But if there is a spike in COVID in the fall, then that's also going to challenge both utilization, revenue, cash flow. And if there's a third spike in Easter of next year, that's again going to be a challenge. Now, that's providing that a number of things do not happen, like significant global vaccination, and we all appreciate what challenges exist with that.
And still to come, the Blake Road facility is activated, and we hear from a survivor, a doctor himself, who was treated at Blake Road.
And I was actually in a lot of trouble from there on. I really deteriorated that day, that Thursday evening, in the quarantine unit.
Welcome to On the Record.
Looking for more On the Record? If you miss our Thursday showing at 8 p.m., join us for the re-airing on Friday mornings at 10, and then again each Sunday night at 8:30. Or go to our YouTube channel and catch up on all of our past episodes. And then like our Facebook and Instagram pages for a preview of upcoming shows and get a chance to ask your questions. Just look for On the Record.
Welcome back. This segment is brought to you by Executive Printers. From as far back as January, the world found out about novel coronavirus or COVID-19. As the cases here began to rise, the partnership between the public and private healthcare systems became even more evident.
Then Minister of Health Dr. Dwayne Sands announced in one of the earlier press conferences that the Doctors Hospital Blake Road facility was identified as a supplemental treatment center for positive patients. It would support the public facilities in a unique private-public partnership.
It is hugely important to us as well that the public facility is protected. So this all came together quite nicely by bringing the appropriate decision makers. And so those decision makers would be the healthcare providers, consultants, attendings, in the infectious disease space, our chief medical officer with the chief medical officer in the Ministry of Health. And following the conversation between the Prime Minister and myself, I framed a response that would allow patients who are identified by this consulting team at either facility, once they meet certain criteria, they test positive, they're seriously ill, they're going to have ongoing inpatient hospitalization needs, those patients, and that's a very important subset, they have to meet those criteria, would be accommodated in a dedicated care facility. So that formula meant that the financial requirements, the payment requirements were taken off the table. The registration requirements remain the same. And we're going to have conversations soon with the government about what the experience has been thus far. Importantly, what the ongoing formula would look like, whether there's a necessity to continue providing the service, and what perhaps a one-year plan arrangement would look like.
Once a patient from the public health care sector is identified, the collaboration begins. As soon as the positive result is received and diagnosis for inpatient acute care is confirmed, arrangements are made to accommodate at Blake Road.
The collaboration, however, is wonderful. The communication, par excellence. We cannot expect anymore. There are phone calls direct. There's no secretary or anyone to go through. The physicians, you would imagine, have worked very closely together pre-COVID. I myself have spent more than 20 years with the Department of Public Health. So all of the nurses from surveillance, that sort. So we grew up together in nursing from students. I won't quote the number of years. We grew up together. So we know each other. Because the health sector is very small. I don't think people realize how small it is. There's only a public and a private hospital on this island. That's it. And so nurses and physicians work between the two, and nurses may have interchanged between the two, working from time to time. And most of our nurses have transitioned from the public sector.
And the hospital's technology team did all it could to make sure the patient experience there was so much better.
They have done such a marvelous work in terms of making it possible for the physicians to view the patients through telehealth without having to go into the room. And that could happen if they would have been there that morning and would have conducted a physical examination and wanted to just speak to the patient to find out if a certain medication had worked well or how the patient is feeling now. They have the capability of doing so in real time. Also to speak to the nurses that are working in the treatment area, back and forth. Perhaps they would want them to do something specific with a patient or want to see something on the patient. You have to imagine that the patients are not only coming with as COVID positive. All patients, if I hadn't said it before, who go to Blake Road have to be PCR tested COVID positive, not the rapid test. And so they're confirmed in their illness. We also have the capability of dialyzing patients out there. So we've noticed that a number of our dialysis patients have been hit pretty hard with COVID and have been very sick. So we've had a number of those that out there as well.
At the time of this interview, well over 30 patients had already been treated at Blake Road. 20 discharged, there were 5 deaths, and 7 remained for treatment. Among those discharged, Dr. Morton Frankson. He was diagnosed in March, having developed symptoms and decided to isolate at home.
I had quite a severe and life-threatening encounter with this disease, COVID-19. For this first 3 days of March 13 to 15, I really had my first set of symptoms, and that was basically dry coughing. And it was an occasional cough, and as it happened, because it was in the news, I started to entertain the possibility that this could be the beginning of COVID-19. And so I kept my distance from people, but in the process, watched to see if there was any fever or anything, and there was none until the Sunday of the, what was it, the 16th, I believe, because I was fine otherwise. In fact, the Saturday before that, the 15th, I actually taught a class at church, and I was fine otherwise. But the Sunday I started to have a bit of fever, more than just the coughing. I also had some pains in my body, etc. That Aleve or Tylenol, Panadol would help with. However, the real seriousness of it came by about the Monday, and the Tuesday definitely I was in a lot of pain, and the fever was more clear-cut, and my taste, I lost my sense of taste and smell. I remember after taking a shower I could not smell the deodorant that I put on or the body spray, and I went to the kitchen, didn't taste anything, and I said, well, let me try some garlic, put it in my mouth and chewed it up, and I didn't taste a thing.
After a call to the hotline, he was told to continue to isolate at home. But as his condition deteriorated, he realized he needed medical attention.
I realized that in the morning, I realized I was feeling pretty good, but suddenly, after I took a shower, I realized it was difficult to bathe. I was getting tired just to bathe. And then rapidly after that, I realized that I really was getting in trouble with shortness of breath. So I made the move of contacting the relevant authorities, and I was told to come in to the Princess Margaret Hospital. I did that. Really, it was a tiring experience. The 2 pieces of luggage I had, I could hardly carry them. The security guard had to help me up the hill. And I was received. I was my hands were washed. I had a nice little device there to wash the hands. Mask was put on, put in a wheelchair, and shuttled into the quarantine unit where they cared for me with a fairly significant dose of oxygen, about 10 liters per minute or so. And I was actually in a lot of trouble from there on. I really deteriorated that day, that Thursday evening, in the quarantine unit, and really needed that oxygen. The fever was there. My vital signs were otherwise usually okay, except for, of course, that my pulse oxygen, they have a little device that reads the oxygen level in your blood by clipping it onto your finger, and it reads it, and it just kept reminding them that I needed as much oxygen as possible. And at the same time, that evening I was tested. That day I was tested with a swab, a nasal swab, and both nostrils, and they continued care with me.
The first swab, surprisingly, came back negative. By this time, he had been moved to the ward at the Princess Margaret Hospital, but the second test proved positive.
So they took me in a rush from the ward back to the quarantine unit and continued to care for me there with oxygen and antibiotic, just to prevent any secondary infection, because as you know, this virus, it does not respond to antibiotics. And the other supportive care, then they made a decision to transfer me to the negative pressure unit that was specially built at Doctors Hospital, both downtown at Shirley Street, and an even more elaborate one at Blake Road, the Doctors Hospital West. So I was put there on the Saturday, and then by the Sunday morning, I think it was, I was shuttled off to the one on Blake Road. Excellent care, lots of supportive care. I got weaker to a point where I lost a lot of weight, and it was a struggle to even try to get up in the bed. The nursing care was so supportive, however, and so understanding. And then little by little, as the day or two went by, I started to feel a little more of a challenge, a little more of a strength coming back, but not much. And the doctors started to challenge by putting me on less oxygen to see how I manage. And day by day, I would show that I was responding favorably.
After a week and a half of significant progress, he was allowed to go home. About 6 weeks later, he has been cleared as virus-free and has returned to work. Still to come, healthcare workers or doctors test positive for the virus.
A small number of our staff would have tested positive, a very small number. The actions that were taken because of that we took that very seriously. We closed several areas and had them closed, meaning of all patients, all staff, and had them deep cleaned.
Hello and welcome to On the Record and the balanced, true and open debate you've been looking for. Around the world, healthcare workers continue to be on the list of the highest rate of infections and casualties. Even here, our very own healthcare workers continue to see a high rate of infection and in even one case, a death.
Dr. Morton Frankson is an epidemiologist. He contracted COVID-19 and was diagnosed in early March.
It probably is that I got it at work. I work as an epidemiologist, and I work along with a lot of young doctors. I do not see patients. I teach and I do research, and a lot of the doctors come to do research. In fact, 2 weeks before I left, a week or two before I left for Trinidad, a lot of them came into my office, and it was quite a busy, overly busy encounter, and I had to manage a lot of encounters with them.
Frankson is one of many healthcare workers who contracted the virus in the natural course of their daily work, not uncommon for many in the field. As a major healthcare facility, though, Doctors Hospital began rolling out a preparedness plan early in the year. But the characteristics evolved, and it presented a lot of unseen challenges.
This disease or this virus, it can be spread from person to person when they're asymptomatic, and it's highly infectious. So we're talking about trying to capture persons without any symptoms from entering into your institution and trying to manage that process. So as the data evolves, we're guided by the evidence, and we have to be able to pivot with regards to managing cases and early detection of cases.
Staff members at the Blake Road facility are in complete PPE, and that's the jumpsuit with the hood and some wear goggles, the face shields, the N95 masks, and that's the entire time that they're in contact or in the treatment area of the patients. And that is ongoing. That wouldn't be changing at all, because it is for the protection not only of the patients, because you have patients, obviously, if they're going home, they have to test negative 2 consecutive times with the PCR test in order to be able to go home. So we don't want you to be, treating a patient who is positive and then move into a next room with a patient who is on the way to getting well, to cause that to go down.
The administration says it was almost inevitable that healthcare workers might have become infected within the facility, given the risks.
And so it's keeping sanity on how you make decisions. And there were differences of opinion about some of the things that Doctors Hospital elected to do. But again, our focus was, how do we ensure that our associates and our patients are safe, and that we make decisions that are sensible? So what does that mean? That means that the only way that we could determine that you are seriously ill and positive for COVID, and you have no other challenges, medical challenges that need stabilizing, is based on how our resources are organized. You require coming to our main facility. So the first thing we needed to do was to create separate tracks. But these tracks at certain points would have a threat of overlap. For example, when you come in, You will meet all of the testing, all of the inquiries about whether it's likely that you may be infectious. We direct you, depending on whether you're able to just see a doctor and go, or you can come in and then be handled in a separate part of the emergency room, and then we place you in a quarantine in the emergency department pending the results of the COVID test.
Yet for their best efforts, some of their staff still became infected. Several areas had to be shut down, and their very own staff were now patients of the institution.
A small number of our staff would have tested positive, a very small number. The actions that were taken because of that we took that very seriously. We closed several areas and had them closed, meaning of all patients, all staff, and had them deep cleaned. And I think you would have heard the minister speak of that in one of his, the former minister of health, in one of his presentations. With bleach and water, that is the choice of cleaning agent for this virus. Those persons, along with persons who would have worked along with them, were placed in quarantine. And an immediate development of a surveillance unit, which has been in place, I think, from March 30th, was established. And that unit was responsible for daily calls to these persons whom we've had at home. And this would lead us into our employee assistance program. We went even further than that in terms of we maintained the pay for those patients, for those associates who are now our patients because they were exposed to us. They were all seen in our facility clinic without charge to them, of course, because it was something that happened on the job. We not only followed them from a clinical standpoint, but anyone that needed help or that was in any type of trouble. Bearing in mind that a lot of these employees are married or living in houses with other persons that assist them financially, and because of the downfall in the economy as of late, with persons being laid off or put on part-time and that sort of thing, that would have affected them as well. So we found ourselves having to assist in those areas as well.
The next step was trying to identify the source.
At the beginning of the outbreak, we would have had an incident where a number of staff members did become infected. And although, this COVID has really been attacking many healthcare institutions and hence the healthcare workers, we were saddened by that. We did have an opportunity to do our own contact tracing. We actually activated our own surveillance team, and I want to say kudos to them because of that, we were able to not only identify the source of what happened and how that came into our institution, but we were able to start doing mitigations immediately, closing down units, high cleaning by the guidance created by WHO, also by having our patients as well as staff quarantined for the period of time. Some had to go in isolation. Our associate health team were able to do the tracing and be in contact with our associates every day. And so we've been really doing well for the past several weeks, as a matter of fact, where we've had no new cases, and we're very proud of that. And we will always do what we can. We know it's not a perfect world. COVID is a interesting bug, but we will do whatever it takes. And every time there is an issue, we respond with mitigation.
The investigation led to a further lockdown and restrictions on admittance.
In terms of not just patients, but also in terms of vendors and contracting services out. And we were able to identify that it was one of those situations where we were paying very much attention to our staff, but not enough attention to contracted services, where those things are a bit out of our control. But once again, disruption brings opportunities and challenges, and we were able to now create new policies that go along the line of contractors and vendors. Also, too, being very careful with using our own people, all right, using our own staff and developing our own. We had already started to create something called the Institution of Learning, where we would train our own staff to do some of the things that we were contracting out, services that we were contracting out. So I think that was a great opportunity for us and a lesson learned.
After that, we kind of went into an emergency mode. We pretty much stopped all visitors from coming into the institution. We implemented immediately a surveillance unit to find and recognize all associates and patients who might have been exposed. The associates were sent home, tested and quarantined. Patients were cohorted. We implemented, cleaning and sanitation of all clinical areas in a phased approach. And then we adopted this universal protective personal equipment or gear policy, such that all associates wear at least a minimum of gown, a glove, and a mask when dealing with patients. This particular virus is created in such a way that even in the best institutions, you'd kind of be naive to think that it's not going to infiltrate your system.
The surveillance and contact tracing also showed a spread outside of the hospital, even though it was believed to have been brought in by a vendor.
We have associates who are not just working in hospital, but also they go in patients' homes, and some of our PCTs, they work along with the home care services. And so, yes, we do feel as though that, it's a two-way thing. Usually, what we've seen in most countries is that transmission occurs from the community into the hospital. Yeah, so we collaborated certainly with the Department of Public Health and Ministry of Health surveillance unit to not only look at our own associates and patient population, but they also, looked into the community and with regards to the contact tracing and quarantining of those individuals.
As the situation evolved, it was clear that they needed more stringent safety protocols. The administration had to make some hard and fast decisions.
What is prudent? What should you do to mitigate, to your question, exposure to your associates and other patients? So we got fairly aggressive with that. And because of that aggression, you saw activity in Doctors Hospital. We try to be as agile as possible in organization, so we make decisions right away and fix it. And so we made decisions on one floor, shut it down, did a deep cleaning of that floor, reopened that floor. Subsequently, a situation arose, shut that down. And in shutting down, that means that we move patients, we test patients, we move associates, we test associates, we send individuals who happen to test positive back home to quarantine at home and ideally isolate from other family members at home. So the point I make then is, as we matured and evolved in the response to this and got better, then you, as anybody else, would hear less and less, and should hear less and less, about situations where, though that is still likely, situations where you have the occurrence of healthcare workers with symptoms in the environment and the whole confusion as to, well, how would they have gotten it? Are they infectious? Are they transmitted to patients, etc.?
The hospital admits the incident was a game changer that caused them to reevaluate a lot of what was and what wasn't happening.
So early on then, if you think about how all this develops, as we all globally learnt as we go, it would not have been a requirement for healthcare workers who work in an emergency department in March, in February, early days, to don what I may call, or we may call a level 2, where level 1 is the full outfit, a reduced version, mask, visor, gown, gloves, etc. And our healthcare workers also work in a whole number of different situations. They may provide home care to patients who may or may not, or relatives may or may not have been exposed and be infectious. They may work in other facilities, including the public facilities. So there are a number of dynamics that I think are really important to understand, that when we started to identify this, then we initiated a testing that too developed its own controversy.
And when we come back, the controversy over the use of rapid testing.
And if we had to do it again, then we would have PCR testing capacity capability right up front. And you can imagine that as the world aggressively shut down, the ability to get the capacity was no longer dependent on money. It was absolutely dependent on every country for itself.
Matt, where in the world is Matt Lauer? Where in the world is Ellison Greenslade? And so these about the low value contingent in Atlanta. So we can talk about it.
On the record tonight, the government's purchase of the Grand Lupine is a hot subject in the news.
At the height of the community spread, Doctors Hospital was seemingly dealing with its own crisis of sorts. After several staff members tested positive for COVID-19, the hospital moved to almost a complete lockdown. They had to, first of all, restrict access. They stopped visitation and high-cleaned several suspected areas. But then the public learned that the hospital was also using rapid tests, thought to be unreliable in some cases.
With several employees now COVID-19 positive, the hospital had to find a way to keep operations going while restricting movement and traffic.
It didn't put us in any crisis, to say that we didn't have staff to take care of the patients that we did have. So that worked out that way. As a manager, though, I must say for me, the turning point was, just the overall concern for my associates, and not only for them, but the fact that they have families at home, who they're going home to. And so the push to make certain that everything that we do is reflective of that, in that we're concerned that they are not infected while they are at work, that we provide adequate amounts of PPEs, that they are alerted soonest. One of the things that we did do was it caused us to acquire the rapid testing so that we can have an idea of who these patients are, bearing in mind that a number of these patients never presented as COVID when they came in, positive that is. So we started rapid testing as one of the means of identifying this, as well as doing a CT of the chest to identify whether or not a person could possibly be put under investigation for COVID, whether or not we would have to go to the length of doing a PCR before we even push them up through the hospital, if you would, if they would be admitted to the floors.
The introduction of the rapid testing raised more concerns, given the issue with false test results, and raising even more questions, like why use them?
And I hear that question often, and my question at that is, why not? It is only a tool. We don't place everything on that tool. It's not something that, and even if and that's why we go further and we do a CT of the chest or a chest x-ray. That's why we take a history. And that's why we do preliminaries like your temperature testing and the questioning on whether or not the person has traveled. So it's not only that, there are a number of things that go into making the decision as to how we treat this patient, not if we will treat this patient. And that's the only thing we're trying to find out. And that's, should we go ahead and place them in a negative pressure room, or should we use complete PPE, or should we say that this patient is safe and it's okay?
Yet they maintain the use of the rapid tests at the time was justified.
It is in our interest of keeping our patients and our staff as safe as possible, and using whatever it is that we can use to stratify our patients as well as our associates. So first, let me say that PCR is the gold standard for diagnosis of COVID-19. It is the gold standard. And we have never used PCR to diagnose COVID-19. If a patient comes in and we suspect them of having COVID-19, they receive a PCR test that is the gold standard globally. So, but what do we do with the rapid tests that we have acquired? We are using that in several ways, and one of them is to screen our staff, especially our staff, because of course, patients who are coming in that we are not suspecting for COVID-19 because we continue to treat heart attacks and diabetes and hypertension, etc. We want to make sure that the staff that are treating them are safe. And, of course, we know about the asymptomatic patients and carriers. And so we want to have something else in our armamentarium. Also, too, we want to be able to later down look at some protocols and institutional research as well, too, using the documentation that we get from our rapid tests. Now, the rapid test is not perfect, but neither is the PCR, which is only 70% sensitive. So definitely, we want to be provide as much as we can for our staff members as well as for the public that accesses our care.
And they continue to use those tests among many other methods.
So we've not abandoned them. What we have done, like I said, is we've changed the way we use them. And we're using them just for our risk stratification. All right, so we've just changed the way we've used them. And, we've also acquired our own ability to do PCR with a gene expert PCR as well, too, that we're gonna use to risk stratify our staff as well. And so we will have that capability for our staff as well as for our patients. And obviously, one of the things that we're going to want to be doing is, as the country seeks to reopen, we want to be able to provide services that would assist with that, to assist the government, assist employers, etc., with that reopening. And because people will want to know, people will want to know, when I open my school, am I going to be able to do that? Or am I bringing COVID in to the teachers? Do I have I'm a contractor. People on my site have to be together. So, we are seeking ways to definitely do that. We're very interested in our national economy opening up and doing it in a safe manner.
Public Health has declared the PCR as the gold standard for testing. It is these tests that are used by the National Reference Lab to determine who is positive. Those results are then made public by the Ministry of Health. The public health officials have resisted using the rapid tests even when there are resounding calls for more testing.
So the rapid test is a blood test that is designed to determine immunity to COVID-19 or the SARS-CoV virus, okay? And so it would assume that you were infected before and now developing antibodies, okay? And those antibodies are said to have developed maybe about 7 to 10 days after you were actually infected. Now, those tests have wide variation, okay? And so under no circumstances are they used to diagnose somebody with an active infection, okay? So the PCR, which is the gold standard, has gaps, it has limitations as well, all right? You can still be infected with a PCR test. You can still be infected with a negative PCR test. And so there still exists gaps in the natural history of this phenomenon. What we have done is we've utilized the rapid test as part of our institutional algorithms to determine, appropriate infection prevention control practices. So along with a rapid, certainly we would do a questionnaire. All right, does the person have cough, fever, shortness of breath, that sort of thing. Along with the rapid, we might collaborate with the radiologists who also have an algorithm to determine the likelihood that somebody has COVID infection, particularly someone who might be asymptomatic. And so that's how we have used that rapid test.
We pressed the hospital's clinical director on infectious diseases on the wisdom of using a test that could produce a false result.
When we first had our few cases, they were actually picked up by our rapid tests, okay? And we didn't get results but from the PCR maybe about 24 to 48 hours later. And so the rapid test, because we were able to get it back within a 45-minute time frame, we were able to implement precautions a lot sooner than the PCR test. Certainly it's not something that you want to fully rely on. No one should rely on a test, all right? That's not what we do as physicians. But you have to use things that would assist you, especially if you're dealing with a crisis or an outbreak that we were going through early on in this pandemic.
So part of that would be looking at the asymptomatic carriers and how that impacted our COVID experience. So we're seeing pockets in Bimini, for instance, but we're seeing clusters in Bimini and sporadic cases in Grand Bahama. So why is that? So, we hope to look at things that will guide us as to what happened in a retrospective study, and hopefully that'll also inform for the future.
And speaking of the future, Doctors Hospital is already focused on the future, even though there is still a lot of uncertainty about it. A going and future concern is still the testing methodology.
And if we had to do it again, then we would have PCR testing capacity capability right up front. And you can imagine that as the world aggressively shut down, the ability to get the capacity was no longer dependent on money. It was absolutely dependent on every country for itself. So if testing and PCR-based testing is available, and it's available in a quantity upfront, that would then avert the argument about what kind of test to do, etc. The antibody test has significant value, but not the same value as the PCR. But we used what we had. The most important thing that the public needs to remain minded of is that we tested rapid as well as PCR. But the results, the information on the PCR was not forthcoming, since that was a monopolized facility. And so 2 weeks or so later, we may get information on the PCR. We use the other information, though, to make decisions. So even if the PCR came back positive when we tested, which in some instances it did, the associates involved, the patients involved, would have already been sent to quarantine at home, just based on the information, the history, the signs, and the symptoms. That is a hugely important message to appreciate, that there's no question then about, should you have tested PCR, which, as I said, either the swabs may or may not have been available, or the swabs were done, but the swabs were not tested for whatever reason, in terms of resources available at the national lab or their own decisional matrix at the national lab. But suffice it to say, we did not depend on that. We assumed that should that be positive, we would have made the correct decisions.
So we navigate as needed, and we're guided by, again, the evidence. We have now PCR testing capabilities, okay? We have algorithms set up, all right? We are going to incorporate, and strengthen our algorithms with our PCR testing. We're gonna continue with the universal PPEs. The flu season is actually right around the corner, right? And so what this has done is it has actually developed a culture of, being aware of what's going on in your surroundings, being aware of appropriate infection prevention and control. And certainly, it's a crisis, but you shouldn't waste a crisis, right? And so certainly the staff and everybody is now aware as to how you actually should perform, to prevent certain infections.
Even their facilities are now better equipped for any future outbreaks.
I mean, you don't remove a negative pressure room once a pandemic is complete. So our capacity has increased, and that's always good. And there are a number of different diseases that can be treated in these rooms, like tuberculosis, for example, and those are things that are still with us here. So that's the good thing. I think moving forward, our organization has embraced the change for the better. We see now that we're moving more towards a personalized service in the future, which we hope to be rolling out in June, more of a concierge type service. So we don't see the hospital just opening, and everybody's just mulling around, moving about. It's more of, I am going, Mr. Sawyer, you're calling in, how can I help you? It's time for my annual physical. Yes, sir, you will need blood works, you're going to need an ECG, you're going to need, and I will be happy to make those appointments for you, tell you where you can park, have a valet meet you, have a navigator meet you, get you to all of your appointments throughout the hospital so that you're not sitting and waiting in a large group, and then possibly have a virtual meeting with your physician if you don't have to see this physician one-on-one.
Again, our staff is very dedicated to patient care. So, and they realized that there was something that occurred that was a bit, I wouldn't say beyond our control, but sort of caught us by surprise. And so hence what we did was first communicated with them very clearly as to what was going on. And then second, to come alongside them to provide all of the support that they needed, from mental health support to even down to financial support, because we were dedicated to really committing to not let go people that, during this COVID time, and to really come alongside of them in every way that we can and show them that we're doing the mitigation. What is it going to be that we're going to do to make sure that this doesn't happen, or that we will assure them that we are taking care of the problem that we think exists. So that then, of course, with the public, obviously, we have a great reputation. Like I said, we've always been very interested in making sure that our patients are safe. So just going on our reputation of having patient safety at the forefront and showing patients that we're doing everything that we can to mitigate this. We are cleaning the hospital, we are closing down units, opening up units, we are making sure that we're able to risk stratify patients with our own methods of doing that, testing, screening, questionnaires. We've even gone to the point of you have to use a bleach solution to enter our facility, because we are very keen on anything that the guidance provides that we can do, we are going to do.
And as a country,
I think we had a government that listened. We had a government that listened to the experts, and they did the mitigation early mitigation, and doing things like locking down, shutting down, restrictions, those were very, very hard decisions, but they were necessary. I think we did it right.
That's going to do it for this edition of On the Record. A special thanks to the folks at Doctors Hospital for accommodating us this week. So on behalf of my technical and production teams, thank you so much for watching. We'll see you same time, same place, right here on The Record.